afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center, and I'm here with our Envenomations crew. So welcome to today's program. As you joined us, your phone or your microphone were muted, and please use the Q&A, the chat function for questions and answers. We've got the little quiz. I've got the answers for those that participated in that. Thank you very much. We do have a post-webinar evaluation, and if you can't log into it right after the program, which will populate in a screen when we're done, I will send it in my thank you email, as always. And again, this is being recorded, and you'll be able to check out the recording on our website. So for today's program, these are our outcome objectives, and of course, our accreditation statement and the relevant financial relationship statements. Everybody's gone through that process. I won't read through these. Everyone's received a copy of them. Our standard disclaimer, you're gonna have 5 seconds to read that. And again, please be sure to check out our website, sign up for our e-newsletters, and find out when our next events are coming up. We're working on 2026 schedule. It's going to be fun and exciting, of course, with this crew. And again, your opinion is valuable to us. Those that are wanting CME credit and certificates of participation, that information will be in my thank you email as well when we are done. So without any further ado, we have a crew here. We've got Dr. Empel, Dr. Klotz, Dr. York, Dr. Shirazi, and Dr. Smilsky, who have done various webinars for us this whole last year. And they're going to be talking about quite a few things. And we're going to be going over the quiz, some of the questions. And I think this would be my last slide in here. No, actually, Dr. York, you want to do a quick little spiel on our...
This might be the last time for this one. All right, so I can't see everyone that's here. Hopefully we've got some new folks, but I'm willing to bet this is probably most of our usual crew. So a little bit of a different approach today. If you are new and joining us for the first time, you could not have picked a better day to come. So for now, several years, we have been giving these webinars focusing on envenomations, intoxications, travel-related diseases, focusing on the Southwest, but expanding out as interest arises. We've been doing this, God, has it been 2.5 years now? When was our first one? Feels like ages ago. But we have discussed every manner of things at this point. In the world of infectious diseases, we've talked about bacterial, viral, fungal things, all sorts of different natures. We've got folks from the Poison Center coming to talk to us about a number of different things. All of the plants, animals, and the terrible things that can happen to you out here in the Southwest. Let's go to the next one. All right, so in the last year or so, we've focused on some more unusual topics. We had started out, I think the first one in the series we did was talking about ORF and some other, I would say, peculiar illnesses that folks may encounter and not realizing that they're encountering. We've done talks on valley fever or coccidioides. I think our most popular ones have always been the rattlesnakes and getting into a lot of data that frankly, I don't think a lot of folks are aware of. Plague, hantavirus, all manner of different things. And the goal of today is basically a roundup. We're gonna just bring all of this stuff back. We've had numerous questions, comments from a lot of the folks that have been a part of this from the beginning. And answering any misconceptions, any lingering things that may have come about. We have certainly had some issues the last couple of times, so if you felt like you were cheated out of anything, we're hopefully here now to do that, although I'm warning obviously up front. But we've got some questions that you all may have been sent or have seen. If there's anything that arises as part of our discussion today, you throw that in the chat. We have got an all-star panel of folks here. We have got Dr. Shirazi, Dr. Smelsky here to talk about all manner of things relating to the Poison Center, rattlesnakes, plants, toxins, anything you can imagine. We've got Dr. Empel, Dr. Klotz here. We've got world experts in things like valley fever, all manner of tick-borne illnesses, and then myself to bring it up. I bring a wealth of Star Wars trivia to you all, and I feel like a critical piece of this panel. So I'm glad to be here, and we'll try to round it out the best that I can. But certainly, if you've got your questions, we have got world experts here. You throw them out there. Essentially, this hour, we're gonna go through some questions. We'll use that as an opportunity to revisit some stuff. But this hour it belongs to all of you. We really want to meet you where we can, answer any missing questions, elaborate on topics if you'd like. So don't hesitate, okay? So with that said, let's get our questions up. Let's see what we've got here. We've got everything ready to go, so don't hold back, folks. All right. Question 1. Contact with what animals might result in contracting ORF? So this is going way back. This was something that we talked about. Goodness, was it even this year? It had to be last year. Yeah. Was it really? I would have thought for sure this was 2024. But our first one in our new series, this was our question. So overwhelmingly, we've got 17 folks, sheep or goats. 2 people said rattlesnakes. 1 said Colorado river toad. I appreciate it. That's about the only thing I've contributed to these series for a while. But it is unfortunately not the Colorado river toad. So I'll have to owe you more than that.
It's a road, not a toad.
River road.
You can get lots of things.
Well, I'm hearing from the traffic, yeah, something's going on out there. Maybe that is the answer. Who knows what's going on? All right. Overwhelmingly, we have got sheep or goats. So I'm going to turn it over to that presenter, Dr. Klotz. Can you elaborate? How could I
shortly? Yes, I can. I think there is a slide there. It's the last.
Need 2 more screens. My goodness.
There you go.
All right.
First.
Is that the first one?
No, next one.
There.
Yeah, so we talked about ORF, and most of you had this correct. It was quite surprising to me. First time I saw it was 20 years ago here. And I think I described to you how it involved a wildlife management student at U of A. And he presented with these very large, much larger than the lesion you see on his finger here. Red lesions, they were swollen. They're like a blister, actually. And inside of it, of course, is all the DNA virus, which is almost visible, by eye. It's best looked at with a microscope, but here's a photo of the ORF particles. And it looks terrible. Patient's fine. They don't have a fever or anything. They have this white rim around it and around the outside of the lesion. And it all disappears on its own, so there's no therapy.
What does the timeline look like for that disappearing if they do nothing?
Oh, I think it took several weeks.
Okay.
Yeah. Just avoid breaking the blister up, but it will. So.
All right.
Got a comment?
Yes, let's go to the comment. So we had a comment right away. Let me address this one. So we've got Dr. Klotz, Dr. Impel that can talk about this one, but chikungunya. I can briefly address the Mandalorian movie. That's my fault. I should have clarified Star Wars. That's Disney Star Wars. That's not academic, sir. That's not what we do. All right, so addressing chikungunya. In general, do you have any specific questions about it? If not, I think my segue would be chikungunya. I do feel like is one of the things we hear about being of concern that's going to potentially have increased numbers here spreading. What can you comment on in that regard? Should we have a heightened awareness for this at present?
No. Well, I'm going to say I thought, and I could be wrong, there was an toxinous case in Long Island. Wasn't that chikungunya? So we know these are Aedes aegypti mosquitoes. And the question is,
it was indeed. First locally acquired case in New York State.
Right, and so that's very disturbing, meaning have these mosquitoes, and I haven't heard any reports on mosquitoes with chikungunya gotten that far north. So Aedes is in Florida, am I correct?
Well, Aedes aegypti we have here.
Yeah, so if there's enough people locally who then have chikungunya, or if we have people immigrating here, which I guess we don't anymore, but if we were, I guess I shouldn't say things. Then that will be, but this case in New York, and that may be why we have the question, because that was very disturbing, and I haven't heard more about, other than this person was, I think, on the North Shore of Long Island. And so that's, how did that person acquire locally an infection we think of with subtropical and tropical regions where Aedes is. So yes, I would disagree with Steve, but that's not new. That we might be a little bit concerned. I will say from the state of Arizona that we see dengue in Arizona. All of those have been imported. So for example, dengue is fairly common in Mexico. And we do have cases in Arizona each year. All of those seem to have, these seem to be related to outside the United States, particularly Mexico. So, but that's going to be the concern is if we get things locally. And I know that's an issue with malaria as well in Florida. So I would say we want to have our antenna a little bit more up based on this recent case.
Then following that up, for the folks that are joining us, we got all sorts of different types. What should they be on the lookout for? What would raise your suspicion of thinking maybe this is chikungunya?
Why don't you go for it?
Well, I think it's the presentation of the disease, which sort of has a characteristic arthralgias are very prominent and very difficult to deal with. Patients are also usually febrile. But other than that, I don't remember. It may have a rash. I haven't.
I don't think so.
In a long time.
So it's fever and diffuse arthralgias. We had a case actually at the VA. I'm not sure that's what she really had when chikungunya first started spreading, which I'm thinking was 8 or 9 years ago. And then there's another issue with chikungunya which was a big problem in Brazil, right? There was because it's maternally transmitted, so it was relating into birth defects. So I think we do want to know if chikungunya is arriving autochthonously in the United States, because it is ultimately benign. It's not like dengue, so you have just severe arthralgias. But if a pregnant woman acquires it, then there is fetal abnormalities and fetal loss. And that was a major issue, as I recall, in Brazil.
I've actually seen it in South Campus. I had a lady that traveled to Jamaica, but that was the reason. And at the time, they had an outbreak in Jamaica. So the only reason we got testing on her is because she said there was an outbreak. This is about 8-9 years ago, actually. But again, if it wasn't a traveler, and if she would not tell us that there was an outbreak in Jamaica, we would have never, I remember she had high fevers and she was complaining of a real severe pain in her big joints, especially.
Any rash that you can remember?
I want to say that she complained of some rash, but at the time that she was there, she was an African-American lady, at least I was not able to detect, but she was saying that she was getting these patches. And I remember we got the Department of Health involved and we'd send serology testing, and it was eventually confirmed that she had it. She was actually admitted. But again, that was through travel. And I know that within my lifetime of being a physician, we had outbreak of West Nile, that again, the mosquitoes are similar. And we had an outbreak in Nogales because of the standstill of water that they have, and lots of like old tires or boxes or metallic or plastic containers that they had mosquito outbreaks in there. We had also outbreak of West Nile, so that can happen. And now with our involvement in Venezuela, that's we have a large number of troops there, so it makes sense to have that as part of a differential.
That's really important to get that history, especially if they've traveled so many. A lot of the diseases you guys have talked about.
That was a very good question. All right, I appreciate it. And then I want to make sure we covered everything. So then we had a question from you, Barbara. Is that often declared as spider bites? Is this in reference, I'm assuming, to ORF? I'm going to assume yes. Do you often see where ORF is misclassified or misdiagnosed as something else?
No, the confusion there is between spider bites and MRSA lesions, skin, which are very contagious. And that used to be number one big diagnosis was spider bites, because we had Oxosceles species through the Midwest and here even in Arizona. But
Again, there's a good paper. It says it's not a brown recluse that gives the distinction between infections versus a brown recluse bite. And we do have 5 subspecies of Loxosceles here in Arizona. Arizona brown spider is one of them. And we have seen some, but it does not look like this.
Interesting.
This is not, they get that hyperemia in the center that then becomes a scar. And it takes a much longer course. They can have a little bit of fever at the beginning, which this doesn't have. But I can see that you go to any urgent care or emergency department, it's the attack of killer spiders.
All right. We had a couple of other questions. I'm going to circle back to you just to make sure we at least keep some of our questions going here. But Kenneth, I see your question. We will come back to that. Okay. Let's get our questions. I'm ready. Let's do this. So the majority of folks got it right. Circling all the way back to the initial question. Well done.
All right.
Okay, so true or false? The most common route of infection with coccidioidomycosis is inhalation, whereas with basidiobulomycosis, the fungus is probably swallowed. So again, majority of folks going true, 2 for false, none this time for Colorado River Road. All right, so it's still about accurate. All right, so let's turn this one over then. Dr. Ampel, can you elaborate on this? Were the folks correct?
Yeah, so let's go over. So first of all, these are 2 very different fungi. I'll come back to that. So coccidioides, of course, is we are a major endemic area. In fact, Maricopa County has the highest rate, the highest number of cases in the country and the world. We only see this in the Western Hemisphere. We don't need none of my slides are going to deal with valley fever. Because John was here, but I can do this. So what we know about valley fever is it lives in the soil, but it's a little more particular than that. It probably lives in rodent burrows and in rodents, and that's a big concept now. We actually think that's how the fungus geographically spreads. The fungus has what we call aerial mycelia. That means it grows above the substrate. So if it's a plate, it grows up, which is why plates of valley fever in the lab are so dangerous, because you pop that, you got aerial mycelia with these conidia we call arthroconidia, which means jointed spore. These break off very easily and you inhale them. They're about 2 to 5 microns. That's a perfect size to get deep into the respiratory tract. So coccidioides is classic for being inhaled. Having said that, most people have no good history for having inhaled this. And I used to have a joke up in Phoenix, North Phoenix in Scottsdale, so that they would understand, because they would say, I went hiking in the McDowell Mountains, that's how I got this. And I said, no, you can go to Kierland Commons, which is a very upscale open mall, going to the Lululemon store from your car, and you can get valley fever. So that's the problem. You can get this from fairly trivial exposures. Now, basidiobulomycosis is interesting. We see that in Arizona, and actually my colleague, Dr. Vikram, reported on that in clinical infectious disease. He had a series of cases. We had one at the Tucson VA, and that fungus is actually more related to mucorales. It's a very different fungus than coccidioides. And it is strange that we usually find this, as in our case, the guy had a a mass in his stomach. It's often associated with eosinophilia and often fairly benign. So they're very different fungi, but that is correct. So probably people are swallowing Basidiomyces, but definitely inhaling. Now you can get an inoculation coccidioidomycosis. We see that occasionally, but most of it is inhalation. Steve, do you have anything you want to say?
No.
Okay.
It's a long pause.
Huh? No, I'm fine with it. I was just thinking about
You
this,
agree? You
this
did a good
wag
job.
who writes these questions about, can you get anaphylaxis?
We want to go.
Okay.
I don't want to repeat my experience at ID Week. I told a joke about walls.
So next one.
If you enjoy the roundup so far, please let us know. We would love to
Or
do
not.
more. This is good stuff. This is good stuff. All right, so I saw the question was already ready to go. True or false, rabies may have an onset months after the exposure. So a little bit more disagreement here. We had our 17 folks saying true, 3 that say false. So for this one, let me turn, Dr. Shirazi, what do you think about, what is the longest you've seen ever take?
Well, I think the one that was a couple of years. I'm not sure.
I thought it was as long as 15 years.
Might have been, but
like 8 or 9
one, again, I'm not an infectious disease expert. These guys
You
are.
never know.
I was,
Start with you.
I don't know, by default told to do that because we answered the after hour calls for the county, I guess, and they wanted to know about it. But yeah, it can take a long time before it's, I don't know, it's because the virus gets
No, it's
activated later
the
or
length, it's how far it is from the central nervous system. So the further you are from the CNS.
But most of them, when I looked at them, most of them are far away from central nervous system. Although neck, face, and upper torso, but most of them are far away from. And but it does not mean that they are correlated with the same amount of time. And again, I don't have any insight into that, except yes, it can happen.
So a couple things, it's just a report of a transplant patient dying.
Yeah.
Yep, we talked
rabies.
on this one, yep.
But I had an experience because my dog, Frankie, who since has passed, but not from this, went and attacked a herd of javelina. And getting him out of there, I was chomped on. And we went through a big discussion about whether I should get rabies prophylaxis. And this went on. And the first thing I just want to tell you, if you get bit by a wild animal and you start worrying about this, you'll have a nervous breakdown, which is what happened to me. But because of this, you do have time. So I would say a couple things. And we are having a major rabies issue in Arizona right now. And I think even in the Tucson's, we may have had a rabid fox. Most of these are actually in southern Arizona and in Cochise and Pima. And so foxes, skunks, to say this, javelina are not, I'm not sure javelina get rabies, but after the discussion. Right, and so that was the whole thing. I said this was provoked, but I ended up getting rabies prophylaxis. So
They're extremely rare, but possible, yeah.
If you, obviously, any a wild animal bite, probably you wanna get care for that and consider rabies prophylaxis. Particularly if it, in a fox, a coyote, a skunk, for sure. Because this is an ongoing problem in the state and particularly in the southern part of the state.
There was a case of a seal that they thought it was rabies, but it was actually domoic acid. It was toxicity.
Bizarre. All right, let's double check. Any questions? All right, good so far on that. All right. This is a good question. I think getting into this, there's a lot of things that I don't think most folks are comfortable with or encounter with any major frequency. But what kind of tick is implicated with tick-borne relapsing fever? So the majority, we've got 10 folks that said the argacid or soft body, but we've got then split between the soft shelled and the hard body. So let's turn it over to Dr. Klotz. What is the answer here? How would you help to discriminate between some of these specific ticks? Maybe if you're out in the field, what might I look for?
In the field. Well, you're not. The bites occur differently. For example, the argacid ticks, our soft body ticks, live or stay and maintain themselves in the homes or old abandoned lean-tos and cabins. So we encounter them when people are camping, they're bitten, and they bite, and they leave. They go back where they came from, and back into the wall. Whereas your hard body ticks, exotic ticks, stay on the body. They're the ones who see and pull off and cause so much mental distress, whether you've got.
Something's gonna follow.
Can we get my slide?
Yes.
We have to find the slide.
Neil talked about
that's-
this.
Yeah, go through some of those slides. Keep going. There, stop there.
We got this.
Okay.
Show that slide.
Second.
And if you watch them, the argacids are really quick moving ticks. We had an outbreak of argacid ticks in inside the hospital out at South Campus. Must have been 8 years ago.
Yes, from the swallows.
Yeah,
They were nests.
they were feeding on
So
the cliff swallows.
as Steve knows, it's one of my favorite words, ridiculous. Not to be, and I'm not mispronouncing ridiculous. So these are nesting. So these, and there's no, they're right there. So that's the tick, soft body ticks. They're ridiculous. And that was actually the cabin, when I was giving this talk, that was my cabin. So it was very disturbing. But what happens, and I got interested in this because we actually had an initial case at Mayo Clinic of relapsing fever, and then we found a bunch more between Tucson and Phoenix. So the idea is you've got your cabin, and pack rats and other rodents have gotten in there, and then you've cleared them out. You've rodent proofed it. You've gotten them all, so you think you're good, but you're not. Because these ticks can last as long as 20 years. As Steve said, they nest. So they're sitting in the wall. You don't see them. They come out at night and they bite you. And it's minimally, you don't know you've been bitten. And then you start coming to the ER with recurrent fevers and people keep sending you away. And you keep coming back. And after a while, either you get over this because you can have anywhere from 3 to 10 episodes of fever, or if someone actually starts to test. But so these are the soft body ticks. You can get Borrelia miyamotoi is a cause of a lapsing fever, and that is transmitted by oxodes, which is the hard body tick, which is the classic tick of Lyme disease. And I had one of those. I was actually hiking on the island of Mull in the Scottish Hebrides. And I found this questing hard-bodied, probably a nymph. And when we got to the town, I mean, they were full of remedies for Lyme and ticks. So even in Europe, Lyme has arrived. There was a form of Lyme there before Lyme was described in the United States. But now they have the same Lyme disease that we do with some different vectors. So the hard body ticks can do that. So that means in areas where the hard body ticks, which is from the Northeast and upper Midwest, you can get a relapsing fever. But most of these are in the West. We could go back.
So I have a question for you. You have here the obligate blood feeders, and it seems that they go among species, whereas in such as a bed bugs, those guys, it seems they're more specialized. They specialize on chickens, or fowl or humans, and it seems the size of the blood cell matters. But it seems in the ticks don't.
Well, these, I'll tell you, dog ticks are very different. They'll quest more for dogs than humans. I don't know, Steve, do you know if the different ticks have a propensity for different hosts? I don't know that we know that.
You know, because the bed bugs, for example, that are specialized in hen and chickens, they can't feed on human
That's
red
interesting.
cells. They actually choke.
Right. Yeah, I don't know that we know that. So what's interesting is you can see the Mountain West is the big area. And you see northern Arizona and the White Mountains, which is the other map shows most of the cases have been reported around the Grand Canyon. But our cases all came from around Greer, which is actually where the first case of relapsing fever, I think in the 30s, was first identified. And I put Phoenix and Tucson there because that's where the diagnosis was made. So people, you know, they go up and obviously have their summer homes up in the White Mountains, particularly in Phoenix. And so when they get sick, they come down to the metropolitan areas. So that's why it's important we're aware. And the other one is you have these cave associated in Texas. So that's where the ticks live in caves, not in nests and walls and such.
Now, do you have any recommendation in terms of prevention? I've had calls, not with regard to relapsing fever, but ticks in general. That should they apply off or rub off, you know, around their beddings in these rustic cabins? Is that helpful?
Well, that's
In a rustic cabin, you're gonna need to get a pesticide control.
Well, no.
yeah, that's the first thing.
That people were
You-
doing rubbing like off as a chemical, you know, off that.
Oh, really? Oh,
Yeah,
you're describing an actual.
Actually, actual calls that people were rubbing it around the surrounding, the tip of their sheets that they were sleeping.
What was the other question?
Well,
does this
that,
work?
is it gonna prevent it? And it's
Well,
like, I
So,
don't know.
so for preventing on a person, that's a great, but yeah, so you shouldn't stay in a cabin that hasn't not only been rodent proof, but also been, what is it, a raricide, what is it? Raricide, it's on my notes, that's been treated.
Cat carrots.
Parasite. But
And labeled rustic.
and actually, that cabin people complain, but I came out, so far I haven't had a recurrent. Personally, what you do, there's the two things. Permethrin is for your clothes, that kills ticks. You can put
I have it
permethrin,
on my hat.
and you can, that's right, you can buy, in fact, I think the pants I'm wearing right now have permethrin. These are my hiking. The second is you use DEET, and you don't need to use anything more than 30%. And that you put on your skin and that repels. So you could argue, I guess, you could spray DEET around. And DEET is really the best repellent. There's picaridin is probably okay, and candles and stuff do not work. DEET is non-toxic. I know it does smell, but it is the best repellent. So that goes on the skin. Permethrin goes on the clothes. So you could argue you could bring permethrin treated sheets, I guess, but you shouldn't really stay in a cabin that you're nervous about.
Oh, I stayed in the same cabin another time.
How are you feeling? These fevers will go. Yeah.
Fevers don't go away, no.
All right, so we're gonna open it up. I anticipate there may be some more questions here. We've been putting it off just to give it its due. All right, so let's flip back to the questions. All right. This I think is a good discussion question. Oh, you're good. Believe me, how you keep track of it,
I gotta get to the right.
you do it. It's magic at this point. We'll believe whatever you say.
Here we go, here we go. All right, here's our next question.
Okay, so yes or no question. If a patient came into the emergency room and they claimed that they were bitten by a rattlesnake, and indeed you find 2 puncture wounds, sure looks like a bite, should you begin anti-venom immediately? And this, I think, was the most split of the options that we had for all of our questions. So we've got Dr. Smelsky here that can comment on this. I think this is a loaded question, so you take it away. This is a good one.
Yeah, I mean, it definitely is kind of one of those, like, how literal you want to interpret the phrasing of things. So with specifically what's there, you have the potential for a dry bite to still exist because all you have are these 2 puncture marks. Now, recalling the talks that I gave where I said that that's not very likely and that if you know it was a rattlesnake, it's probably 3% or less are actually a dry bite. The practicality of, patient benefit of starting a preventative medication, I could see an argument for you should probably just start it. But again, it depends on what side of caution you want to err on. So if you're want to avoid administering antivenom as a rather expensive treatment and all of that kind of pieces to it, you could be very diligent about looking for the dry bite, which really we look for no symptoms beyond a mechanical puncture. And so it really would need to be an asymptomatic, you just have a couple of punctures. Once it expands beyond that, it can start to go rather fast, and you would certainly want to have antivenom going.
Jeff, can you talk about what it would look like if there wasn't envenomation? So presumably the patient took anywhere from 20 minutes to an hour to get to the ED. What would that look like if it did envenomate? In those cases.
So you get the whole spectrum of an inflammatory response. So erythema is very common. You get edema because the venom is damaging the capillaries, and so you start to get some localized swelling. And then you get the tenderness that comes with the inflammation. And so again, depending on the thickness of your human, you may or may not pick up on how much swelling and edema is there. You also could start to see some of that vascular damage in the form of bruising. And depending on what venom toxins are in the particular snake that bit you, which one is going to present first could vary. And so we talk about all these group of symptoms somewhat ambiguously on purpose because any one of them might be the first thing that you get. So again, it's the first thing that isn't a cactus poke is kind of your cue that it's an envenomation, and then try not to get too lost on the nuances of the other things. The vascular damage is fairly universal in Arizona rattlesnakes, as is the inflammatory response, and so they all will eventually present. But the leading idea is that because the venom isn't considered active when it's deposited, you have this potential time delay before the local effects activate the venom, so to speak. And then kind of the damage and subsequent signs and symptoms start to present. So,
as a practitioner that I've done it in the ER, I've been in the ER. We have had people who came in, I remember in early parts of the opioid epidemic. We had people that actually put 2 nails in a 2x4 and hit themselves, came in and they claimed that they knew it was big Western Diamondback. We had one that came and said it was a Mojave, and it can only be treated with the antivenom, but it needs to have also the other D drug to be given. So those things happen, and I think most of the experienced practitioners in emergency medicine, they sort of balance it out. Unfortunately, still pain. We describe tenderness as when we elicit by poking it, but pain's still not as accepted as the general part of the signs and symptoms, although we have not seen anybody that has swelling, erythema, ecchymosis, and pain that wasn't. And they had a good story that wasn't. But again, you have to be like anything else. You have to have that always in the back of your head. Is there a secondary pain? And that's unfortunate, but we have to do it.
How did you differentiate between snake bite and 2x4 attack?
They have a nail coming out of there.
It was too symmetrical, and of course,
Interesting.
that treatment usually is we treat pain, but you don't come in and say the only treatment is the D one.
For sure.
They give you a name and then nothing happens. Usually we observe them. As a matter of fact, both Dr. Slimsky and myself are working on different protocols for physicians to look and evaluate. And there is some time. You have some time, 10 to 15 minutes to evaluate progression. And usually with envenomation, there is some degree of progression that you see. We like to get there fast, but at the same time, both the pricing of the antivenom and with the unfortunately other mitigating factors, you don't want to be always, pulling the trigger all too fast.
But if you see the 2 punctures and you see evidence of inflammation, swelling, you would always give.
And remember, you don't need 2 punctures. And the snakes rarely they go symmetrically put 2. They can hit one, they can scratch you, and I have seen them so that the puncture wounds are far apart. that it was a titanoboa. And it's because they hit and they can come back, hit you again. So even one puncture would be enough.
Yeah, but with the inflammation
Yeah,
and
exactly.
the story.
Correct.
Yeah, and I think that was the thing I was trying to emphasize when we were doing the presentation earlier in the year is that the value of the patient's history. So, you know, about 3% of people that actually saw a confirmed rattlesnake ended up not getting antivenom. Yet 20 to 25% of the people that show up in an ED and say, I think I got bit by a rattlesnake, don't get antivenom for examples like Dr. Shirazi, because it's still coded as a rattlesnake bite, depending on how the systems are coded. And so, you know, that difference of is it truly a rattlesnake is probably of a lot more value than we're appreciating.
Interesting. And then that you had mentioned monitoring for the swelling. So we have a write-in comment. So in veterinary medicine, we have a comment from Sally who mentioned that they immediately run a CBC and look for signs of swelling and do a blood smear looking for crenated red blood cells.
We don't do that in humans. It doesn't do that. In animals, we have actually a project, we're looking at the thermal camera. The thermal camera is good for acute envenomation, but unfortunately, if you have a significant also or a mild infection, there is also that thermal gradient that show, but thermal camera can help. And they're becoming cheap enough that maybe one of these days they'll get it.
I think every time we do these discussions, I think it's just fascinating how much new stuff you all are doing. I mean, I think that's what we all miss out on. And then I saw the comments earlier. So right away, George, you get all the credit in the world. I saw it could be a dry strike right away from there. And then Barbara, so 2 rattlesnake bites that were flown from Portal that ended up being dry bites. So I am curious, do write in why were they flown? Did you get a history? What do you remember about those? More just for general interest, honestly. But any other questions on rattlesnake bites? Anything here?
We have an insight on Portal. In Portal, there is that similar to infectious disease conference that we have. There is also a Envenomation conference. There has been both Venom Week and biology of rattlesnake. We have actually had also biology of the pit viper, biology of Gila, and they do have a museum, which is like a zoo. They have rattlesnakes there, and we have had people who are actually handling them getting bit.
Is it the one right off that turnoff?
Correct.
Yeah, I was gonna, why are there so many bites down in Portal?
Yeah, it's because they have
That's
that
the
museum.
thing.
And it's always been since I would say go back to Finley Russell and even before that. There are lots of physicians, anesthesiologists, our own friend Esco is down there, and that they dabble into what we call amateur herpetology. So
Yeah.
All right, we ready for the next one?
We're ready. All right, let's see what our next one is. All right. All right, so a little bit of a change of pace here. So everyone who contracts West Nile fever progresses to encephalitis. So we've got 1 saying yes, we've got 19 who say no. So, oh, no worries. So probably, I think you've got a slide for this one.
I do, but I could, yeah, so most people are correct. It's about 1%. So most people with West Nile who are symptomatic, most people are not symptomatic at all. Then keep going, it's several slides down, Melanie, but it's about 1% have encephalitis. So how does that differ? So most people present with a headache, and that you can have a rash. And it usually lasts 1 to 3 days. But in about 1%, it's much more severe. And so people get encephalitic, which means they're not thinking very well. That can be anywhere from depressed mental status to coma. And in fact, bad cases of West Nile, I didn't quite get this in my talk. Keep going, there's a thing.
This one?
Right, there we go, there's clinical disease. Yeah, so fevers, headache, that may come to medical attention or may not. But neuroinvasive disease, so you have this altered mental status, and that can be profound. And we've had a couple of cases where the real problem with that is the prolonged recovery. So, and I have to say, I think I just saw it in IDSA News. So there's just a paper, I think yesterday. Who gets this? It's just who you'd think. older age groups, people with underlying disease, particularly people who are immunocompromised, are much more likely to get a neuroinvasive disease, which, as you can see, you get these tremors, altered mental status, maybe nuchal rigidity, can have a flaccid paralysis, is actually a Parkinson's syndrome seizure. So that part of it is uncommon.
So having seen this, I actually have had patients both with Todd's paralysis after seizures, with West Nile. Is there a therapy that could be acutely developed?
Well, that's the issue, and essentially, no, there is no established therapy for severe West Nile. So that's the problem. So it's
And
just
would
supportive
steroids help?
I think there's been some data
There's a little
on,
bit of
yeah. Steroids. The other thing is about a vaccine. This is an interesting area. There's a horse vaccine, and it's a good vaccine. But there is no human or clinical vaccine for West Nile. There could be. And this is this problem with vaccine development. And this is before the current administration and outlook on vaccines. It's very expensive to develop and test vaccines. And so we've never had a human West Nile, but horses routinely get vaccinated because they are other than birds, a major equines are a major. So, Steve, do you have anything?
No, I was just, well, some of the questions that were just one guy or one woman, I can't tell the sex by the question, but they're just hilarious. They could be on TV.
Should we go to the next question?
Let me circle back here some more. Is there any comments? We got an EMT from Portal saying that they've flown a number of snake bites and haven't heard of any that were dry. Did you notice any unusual patterns?
We have had actually multiple pretty bad bites from them. Now, all I can say is for HIPAA purposes.
Well, we wrote in the latest paper 20%
Wow.
of bites are drawn.
Well,
Yeah.
in the context
That's a
of,
little higher than your 3%.
But that's different than when you're holding a snake in a show and tell that bites you.
right, again, that's the percentage of people that show up in the ED and say, I think I may have been. But there are people that, their hand is in a bush and then they see a snake under the bush after, and there was no actual vision of a strike occurring, and then they have a scratch, and so was it from the snake, was it from the bush? So.
I just have to say, because you guys taught me this, because I run into rattlers. I haven't had one this year, but almost every other year there's a rattler on my front. And what to realize is they are as afraid of us as we are of them. And if you leave them alone, they are likely to try to find a way to get away from you. And that has been my experience. Is that right, Jeff and Monica?
Although we have had a pretty late, with the weather getting warm, especially around afternoon, even in December, we had started having bites. And those are pretty much people that were either stepping on them because they're laying down on asphalt to warm up, or bending down to do something and doing some gardening and sitting on them, not paying attention. So most of the time, if you see it and you refrain from interacting, you're okay. But lots of time people, are reaching down, like in the summer, is that hissing. They hear it, they think it's their water going off, and they try to turn it off, and it's
The audience may remember that Dr. Spelsky presented a great video of a family walking over and around,
I had that with my dogs. The snake was stretched out. The dogs walked right over it. And yeah, because it was stretched out. Yeah, because it's trying to not interact with large mammals because they rarely do well.
Yeah, it's not in their interest by any means.
Yes.
And some of the herpetology folks that I do some work with, according to them, I'll just kind of quote them here. They say that if you have snakes on your property, they essentially learn your behavior patterns and will kind of
Interesting.
evolve to avoid you. And so people can live with snakes on their property for several years without ever encountering one.
Special little buddy.
Nice.
I'll tell that to snakes on my property.
Dr. York, we're getting close to our hour. Do we
I know where, let's see
Go
here.
back up to the top question?
Let's do, yeah, we had the question. I promised you, Kenneth, we're coming back. All right, so we had a comment. So almost all my patients that are flown off the reservation have precautions for Rocky Mountain spotted fever on their charts. Anything that he in particular should be paying attention to in regards to this, as it relates to Rocky Mountain?
So 15 years ago, there was a major New England Journal of Medicine outbreak on the White Mountain Apache Reservation. Why? Because it was loaded with ticks, not just ticks on the dogs. Ticks were on the on the walls, and this is what Steve Rhipicephalus and Dermacen. These are dog ticks, but they will bite humans. And we actually had a patient transferred to the VA, and we were told this was a dialysis patient. CDC actually called me and said, "You have to start doxycycline." And I said, this is. So what we usually think of as Rocky Mountain spotted fever, severe headache with a rash that starts on the extremities, usually on the ankles, and works up. So, but if you wait for that, you have increased mortality. So at that time, in the middle of that epidemic, if anybody just had a fever, just treat them first, because diagnosis takes a lot of time. I think that epidemic on the reservation has abated, although there is a lot of Rocky Mountain and also Ehrlichia in the dog population, particularly on the various reservations. So I would say if your patient has had a tick exposure on the reservation and has any symptoms, you could consider empirically treating them. I'm not sure why this is going in every chart.
No,
This is a standard in hospitals. And
I can tell you that it was one of our colleagues from here, who's a pediatrician, trained actually here, trying Rodrigo VR, who was involved with Dawn Autumn. And we were having such a outbreak. And this was even, we're talking about maybe up till 2019, that any fever in any of the native nations, we worked them up for Rocky Mountain spotted fever, and we treat them because we had 2 deaths in children, and I believe there was an elderly female that also died from. And I've actually participated in pesticide, spraying with the CDC in some of the reservations to prevent this, but still the incidence is very high. And most of the Native American hospitals, whether they're part of the the native care or they're part of private, they do a workup immediately. And that's automatic.
But Mazda, the whole point, but part of the workup, if that's the situation, as Mazda just described, which it was when I was involved as well, is you treat, because it takes time to make, and
we
people
treat
can die.
and then you send off.
There's a significant mortality to Rocky Mountain spotted fever. So you treat first,
Exactly.
and then you work up. You do not withhold treatment, kind of thinking about it.
Yeah, so they come in, you draw the blood, you start them on biopsy.
Exactly.
And I would tell you, they came in with any fever.
Yeah.
That's what you did till you could rule it.
Because I'm trying to remember like the timeline, isn't it? You really need to get started within 2, 3, like worst case. Where is it that you start to see the point of no return or major issues?
Well, that's hard. No, well, that's hard to say. What we just know is I think once the patient presents with microvascular disease, which is what the rash is, that's what rickettsia do. They call it microcapillary destruction. Then that can be too late. And so the recommendation is exactly as Mazda said, and that's exactly what I was told. Because I'm saying this is ridiculous. This patient is nothing. There's no rash, and they said we don't care, because the second you entertain the diagnosis with a high perception of risk, you treat. At any point after that, the mortality is going to increase. I don't think there's any
exact
No,
time
Gotcha.
of like, yeah, you have
Uh.
3 hours or 4 hours.
Larry, you should probably end this, I think.
Yeah, that was our last big
Just
one.
end it.
Was a good. Thanks, bye.
Should we look at some of the questions that we wanted to discuss?
Some of them will get us in trouble though.
Well, then don't
They,
answer.
not submitted by us. This is all you. I'm not responsible for this content
These
by any
things, you
means.
don't know how these people
Oh, I
are.
think you
They're
got-
very vindictive.
Cystocirrhosis, right? Cystocirrhosis.
I thought he had toxo. I
Was it
thought he had
toxoplasmosis?
I thought he had
What's
toxo.
cystocirrhosis, that flu.
RFK. I guess
Because
toxoplasmosis.
cystocirrhosis, we see all the time. I remember when I was in Texas as a resident, we had tons of migrants and immigrants from South and Central America that had it. And most of it was calcified and or they would come in with one-time seizure and then we treat them.
Well, that makes sense. Yeah, I always thought because toxo is more common, that he just conflated as is his want. You know, a worm with a parasite, yeah. So I thought, well, yeah, and he was eating raw meat, so you know.
How about some of the other questions?
So I'd say common Chagas disease, how common is this in the Southwest? This is a very quick answer. I will turn over to Dr. Klotz.
Well, it's endemic, it's an enzootic, it's amongst a lot of different mammals. And found in the Southwest and obviously throughout the United States. But amongst human beings, autochthonous Chagas is extremely rare because it's not documented. And most of the people who've been claimed to even gotten it because data was taken from blood studies or antibody studies of people who donated blood. Most of those individuals had all been to an epidemic area or endemic area in Latin America in the recent past. So there are only about 8 or so that are claimed to be autochthonous.
And there's just a Lancet infectious disease, I know, because my colleague Mary Wilson just reviewed it for an NEJM clinician. So there's a big paper now on Chagas, if people are interested.
Then real quick, how many bites involving coral snakes each year in the US?
I would tell, it's been a while I looked at that, but there's tens. And most of them are in Southeast, mainly Florida and Texas and Louisiana. We don't, our coral snake is very fragile snake, very small, and doesn't, we have had bites of it, but really wasn't much of an envenomation to talk.
All right, we've probably, any others that you see?
Yeah, there's a scorpion
Yeah,
one.
I know, we were.
Well,
right,
you know,
yeah, we're some quick-
most scorpion envenomations, they are not your Centroides sculpturatus, so it's not the neurotoxic. And applying cool compresses to it will localize the venom and it will decrease the pain. You don't want to leave direct ice on the skin, and I say this because I've seen it done, and then you have a skin breakdown. But if they showing signs of neurotoxicity, then benzos and trying to get your IV started so that you can get them to someplace, especially for a child to get that to. For most adults, just cool compresses.
Okay. Everyone, thank you very much for attending this webinar. We all enjoyed it. I'm particularly glad to see the gentlemen here who all participated in really amazing webinars. And I hope we'll have the same going forward next year.
If you've got anything you want to learn about, you mention it in the comments. We absolutely pull from that list, so please keep us in business.
So in the evaluation, please go ahead and put your ideas for 2026 for us, and we can add that to our potential list. And again, thank you for joining us today, everybody, and thank you to all of our docs. Thank you very much for participating and for talking, and we have a great following. All of our EMS and that are doing any other treatments. So again, thank you for joining us, and we will see you in 2026. Thanks, everyone.